Very pleased to welcome you to this Global Health History Seminar on Evidence-Based Medicine and Health Policy. I'm going to briefly introduce the speakers who will speak in turn. They'll let you know whether they're willing to be interrupted, but in any case we will have times for questions at the end. Please note that this seminar is broadcast, so we need you to turn on your microphones if you wish to speak, and please introduce yourself. We will also take questions at the end from our online audience. First, the way that these seminars run, for those of you who haven't been here before, we have an external speaker, a medical historian, a social scientist, somebody working outside WHO in this area from usually an academic perspective, and then one of our internal WHO staff gives the WHO angle on the topic. So I'm very pleased to welcome, as our external speaker today, Professor Davidovitch, who is an epidemiologist and historian of public health, chair of the Department of Health Systems Management at the Faculty of Health Sciences in Ben-Gurion University. His research interests are health policy, inequalities, vaccination, public health histories, and global health. Very broad field. He serves on several international and national committees, including the Executive Committee of the European Public Health Association, the head of the Middle East chapter, the International Society for International Epidemiology, and the Israeli Advisory Committee on Environmental Health, and he is chair of the Israeli Public Health Association. And as you can imagine, with such broad academic interest, he's published over 100 papers and book chapters and co-edited books and published work in other forums. So we're very happy to hear from Professor Davidovitch today. Thank you.
Thank you so much for the kind introduction. I want also especially to thank Professor Sanjay Bhattacharya for inviting me, and of course here the WHO headquarters. Before I'm going to start, since I'm coming from Israel, I would just want to say a sentence or two about the situation. As you know, things are quite in turmoil in the Middle East. I really hope that things will calm down. I just want to say that at Ben-Gurion University, also in other universities, we have a lot of collaboration with our Palestinian colleagues. I wish that things will calm down, and I really hope also that the public health community in Israel and the Palestinian Authority will serve as a bridge in order to bring peace to the region. So today I'm going to speak about evidence-based medicine and its connection to health policy from a critical perspective, bringing my own background as an epidemiologist and also as a historian of medicine and public health. Evidence-based medicine developed as an attempt to ground clinical practice on scientific facts and diminish the idiosyncratic scope of different therapeutic approaches by basing clinical research on statistical methods, using randomized clinical trials, and also meta-analysis and other approaches as emblematic methods. Since its introduction in the 1990s, EBM became one of the most influential concepts in the medical sphere, from clinical practice to health policy making. The development of evidence-based public health followed the emergence of evidence-based medicine as an attempt to ground health policies and interventions on sound facts. Today, I want to present a critical evaluation both of EBM and EBPH, evidence-based public health, discussing the limitation of reducing sometimes scientific explanation to statistical analysis and other empirical procedure, and accepting an up-to-date positivism as the best form of valid knowledge. I'm very aware about the recent development in evidence-based medicine, and I think nowadays evidence-based medicine became a much more sophisticated approach. The problem that many times in practice, the way that is being perceived by rank and file physicians and some policymakers is still rooted in a very, very empirical and positivistic form of knowledge. And I want today to suggest some dialogue between evidence-based medicine, epidemiology, social sciences, and humanities. So I want to start with some definitions. According to Davidovitch, one of the central figures in the development of the EBM, and I'm quoting here, you can see in the slide, evidence-based medicine is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. While this is still one of the most cited definitions of evidence-based medicine in medical literature, other definitions followed that broaden its scope. Evidence-based medicine, I'm quoting one of them, involves the delivery of optimal individual patient care through the integration of current best evidence on pathophysiological knowledge, cost-effectiveness, and patient preferences, end quote. EBM is rooted in 5 linked ideas. First, clinical decisions should be based on the best available scientific evidence. Second, the clinical problem, rather than habits or protocols, should determine the type of evidence to be sought. Third, identifying the best evidence means using epidemiological and biostatistical ways of thinking. Fourth, conclusions derived from identifying and critically appraising evidence are useful only if put into action in managing patients or making healthcare decisions. And finally, performance should be constantly evaluated. A crucial aspect of the claim that clinical decisions and health policies must be based on scientific evidence is to define what scientific evidence means. In order to do that, evidence was classified according to a hierarchy of valid evidence, a hierarchy that actually is very much grounded on a very positivist approach to science. In line with this hierarchy, randomized controlled trials are considered as the best evidence, followed by other trials, observational studies, comparison of descriptive studies, and the finally expert opinion and case observations. Later on, meta-analysis and other systematic methods of evaluating statistical data based on results of several independent studies of the same problem tend to be even higher in this hierarchy, termed by some as, I'm quoting, the platinum standard of evidence. Now, again, I'm aware there are much more recent sophisticated presentations, but still, I think if you go to many of introductory courses in universities, you see that these schemes are being used and are still very influential. The conceptualization of evidence-based public health follows the concept of evidence-based medicine. Thus, EBPH is defined, I'm quoting here, the development, implementation, and evaluation of effective programs and policies in public health through application of principles of scientific reasoning, including systematic uses of data and information systems and appropriate use of program planning models, end quote. Others see the role of EBPH as, I'm quoting, call for a solid knowledge based on disease frequency and distribution, on the determinants and consequences of disease, and on safety, efficacy, and effectiveness of intervention and their costs. Following these definitions, the steps of EBPH practice sometimes are described as the formulation of a clear question arising from a public health problem, searching for evidence, appraisal of evidence, selection of the best evidence for a public health decision, linking evidence with public health experience, knowledge, and practice, and with the community values and preferences, implementation of useful evidence in public health practice, evaluation, and teaching. EBPH main tool and process are meta-analysis that I mentioned earlier, also risk assessment, that is determining the risk of a population to suffer from a certain condition, cost-effectiveness studies, that is assessing whether a certain intervention is justified in terms of its cost, vis-a-vis the saving in possible future treatments and the gains in quantified health status using, for example, QALYs. Surveillance, the ongoing systematic collection, analysis, and interpretation of data. Expert panels that will review the data and recommended action, and consensus conferences. While it seems that EBPH practices are more diverse than of traditional EBM, in practice, and again here I'm also talking from my own experience in Israel and also from what I know from other countries, many times still quantified data serve as the pinnacle of evidence. More discussion on EBPH focus on enlarging the options beyond randomized clinical trials that most of the time are not appropriate for public health intervention, to observational studies that are common in public health practices, or recently in methodologies such as community-based participatory research, etc. Now I want to move to the historical roots and to understanding the introduction of quantification in medicine that I think is very important here. Quantification in medicine is part of the growing trust in numbers that has gradually expanded to all aspects of social life during the past centuries, and here the many books that were published about the history of quantification. More narrowly, it is part of a process of objectification in clinical medicine that has been going on since at least the 18th century. It has been most evident in diagnosis, which has come to depend less and less on patients' account or physicians' subjective judgment. And probably you're familiar with the historical work about the stethoscope, introduction of the stethoscope, and furthermore the work of Pierre Louis in Paris. So less counting on physicians' subjective judgment and more on objective science that, in theory at least, transcend subjectivity and compel agreement between qualified observers. Now, in many ways, at the beginning of evidence-based medicine, we find a similar sentiment. And here you can see one famous quote from New England Journal of Medicine, 1971, when Christian is saying, "In my clinical experience," is a phrase that usually introduces a statement of rank, prejudice, or bias. The information that follows it cannot be checked, nor it has been subjected to any analysis other than some vague tally of the speaker's memory. The biases of eminent men are still biases. Now, it is interesting to know that both advocates and opponents of evidence-based medicine have made the very same connection between evidence-based medicine and the numerical method advocated by the French clinician I mentioned, Pierre Louis, during the first half of the 19th century in Paris. What is interesting, though, that while the proponents of evidence-based medicine use it to emphasize the historical legitimacy of the enterprise, the opponents argue that there is nothing particularly original about evidence-based medicine, and I'm quoting here, "Old French wine with a new Canadian label." But some of the, of the origins of evidence-based medicine were, of course, in Canada. Now, we should remember, though, that while diagnosis of illness had, by the early 20th century, become highly objectified, the same was not true of therapeutics. Doctors and patients continue to define success subjectively. Quantification of therapeutics, despite some early historical examples, such as the evaluation of smallpox vaccination or scurvy treatment, that usually also are mentioned as a kind of a continuous lineage that can be very problematic, but they both continue to be highly controversial, as claims were made by many physicians that one, quantification did not work from a methodological point of view and also from theoretical point of view. Second, that the use of quantification in directing clinical judgment limits the freedom of doctors. Thus, historically, for centuries, counting and quantifying actually did not enjoy a high epistemological status by many physicians. In the 19th century, for example, doing laboratory work was considered to be the pinnacle of scientific medicine. And probably I must say, and again, I'm an epidemiologist also, that still laboratory men, if you're going to ask them what the opinion about epidemiology is, I'm not sure they think that they're doing real science, right? So these sentiments are still here with us today. The development of the pharmaceutical industry and its therapeutic products, together with the rise of more sophisticated statistical methods during the 20th century, gradually changes the place of quantification in medicine. The rise of new methods in epidemiology, mainly the randomized clinical trials, the work of people like Bradford Hill, Dole, etc., especially about smoking, brought to the fore the practical importance of quantification in the clinical realm. So although the use of statistics in research with control groups and even with placebos existed sporadically in orthodox medicine, and by the way, and this is not the topic today, it's interesting to see that homeopathy was using placebos and comparison between control groups already at the early 20th century, although I'm not trying to claim the anachronistic idea that this would follow later. But the watershed line is probably the Second World War, that constituted an important landmark for its adoption by the medical sciences. The link between the establishment, scientific community, industry, and the call of the hour, central in the development of new war technologies, served as a model that changed the perception and production of science. from the lone scientific scientists working in a modest laboratory to large working groups, access to massive funding and the support of the establishment and industrial concerns. The world of clinical research also underwent a transformation in those years, symbolized by the research into penicillin, streptomycin, polio vaccines, research which in fact laid the practical and theoretical foundation for the status of randomized clinical trials as we know it today. This epistemological turn, the move from the laboratory, the move from the subjective idea to a much more quantified realm, focused how to authenticate medical procedures. It is important to stress that the flag bearers of this revolution were no longer the laboratory men who in certain sense became natural, almost taken for granted part of the scientific medicine scene. And in parentheses, physicians also resisted in the 19th century the laboratory and its importance. What is the relevance of animal experimentation to medicine? But already in the 20th century, after the Flexner report, after the introduction of the preclinical basic science scientific learning, this time, this kind of second revolution, the objective was not how to harness what is called in medical school world the basic sciences for the good of clinical diagnosis, but to give clinical practice scientific respectability by turning the treatment interaction into one that could be empirically tested. And here we're talking about this period after the Second World War as very important, and I see it as a kind of a second revolution. So it's very important to understand the role of the emergence of the new epidemiology together with clinicians, okay, working now in hospitals and not just doing studies on population at large, that finally from this emerged evidence-based medicine. So now we have from the 50s onward a new research hierarchy as manifested in medical schools and textbooks that was constituted. And indeed, during the last decades, research that is not randomized clinical trials many times have very little chance of being published in leading medical journals. This process was accompanied also by the rise of new regulations and institutions. And here you can see in this slide some factors that were driving evidence-based medicine, and definitely the rise of the pharmaceutical industry is also very important here. And with its regulation, institution, the FDA, the WHO, of course, also has its own role in this process. That again is an important process. I'm not trying to discard it at all, but I want to understand the historical development here. So randomized clinical trial became, for a period, the gold standard for introducing new therapeutic agents, the most important way to guarantee reliable data on drug safety, and more important, on drugs efficacy. While randomized clinical trial became the golden standard to assess the effectiveness of drugs, during the same period, the field of clinical epidemiology, meaning the use of epidemiological thinking and methods, not only in population but also at the bedside, emerged as central for guiding medical treatment. Clinical epidemiology drew on the methods of epidemiology and biostatistics to develop systematic ways of ensuring, and I'm quoting here from a sociologist called Daly. She wrote a book about the emergence of evidence-based medicine. I'm quoting, "The best clinical data are collected and accurately interpreted, leading to well-justified treatment or management plan." Clinical epidemiology linked to the call for medical education reform led to the introduction of courses related to PBL, problem-based learning approach in various medical schools, sometimes new medical schools like Case Western or other younger schools that were established maybe in the 60s and 70s that were dealing with medical education reform and how to create a curriculum that will be relevant for clinicians. So if we take the Flexner report from 1910, that is mainly introducing basic science of the curriculum and the preparatory years of basic science or pre-med as it's called in the United States, here we are talking about introducing clinical epidemiology and PBL. And this kind of thinking that was developed by Sackett and others actually finally emerged later on during the 90s as evidence-based medicine. Another, of course, important initiative that contributed in providing the foundation for EBM was the Cochrane collaboration, an international network started in the UK that compiles evidence of what works and what does not work in healthcare, evaluating the medical literature in order to put forward recommendations for clinical practices, of course, still ongoing and still very, very important. Now, it's very important to understand that from its inception, evidence-based medicine was not only about quantification. It was posed by its supporters as a deep epistemological turn, aiming to give clinical practice a factual solid foundation grounded on the use of quantitative methodologies and biostatistics. It was not just an epistemological term, but it was also presented as a very important step in order to democratizing clinical medicine. Like with the citation before, not being based just on authority, not being based about a professor that is going with his students and saying, my experience is this and that. Things that for centuries were very prominent in medicine. By the way, I think still prominent in medicine. I'm sure that all of you know that in the same hospital there can be different departments using different protocols, mainly because this is how the professor, the head of the department, is actually is suggesting. So I'm not sure about the democratizing process, but definitely this was there from the beginning. Now, the translation of evidence-based medicine to the field of public health is something that, as a public health practitioner and public health historian, I'm very interested, of course, created several important challenges. Moving from clinical problems, solving approach to the population level, moving from treatment to prevention, lack of randomized clinical trial from both practical and ethical reasons, and the multidisciplinary quality that I'm very proud of the field of public health that involve both quantitative and qualitative methods already. Nevertheless, if you take the literature and books that were published, it is quite clear that evidence-based public health turned to be an important force within public health. Now, systematic review, of course, is a very important aspect here. I mentioned the Cochrane collaboration, and I'm sure that all of you are very familiar with the visuals that are being conducted and the meta-analysis. And we'll return by the end to the question of what finally should be included in this kind of meta-analysis, because as you can understand, as you know, this has really important influence in terms of adopting new policies, regulations, many different interests that are involved, including economic interests. Now again, I myself doing this kind of work, I'm not trying to discard it, but I just want to be aware about soon about the problems. You can see some of the groups that are involved now in EBM and meta-analysis. This is from the United States, but it's in many other countries, and not just there. Government agencies, academic institutions, professional societies, for-profit, non-for-profit, medical journals, managed care companies, pharmaceutical companies, different consumer organizations, individuals. So we see here the spread of evidence-based medicine as a very important tool here. Now, after setting the stage of understanding the rise of evidence-based medicine, evidence-based public health, from clinical epidemiology, from this second revolution that I mentioned before, and also the medical education revolution during the 60s and 70s, with really the urge to democratize decision-making, I want to now go and discuss some philosophical criticism of introducing statistics and quantification and some limits of positivism. So, from a philosophy of science point of view, it is really interesting to see how evidence-based medicine and evidence-based public health, at least in some of their presentation, and again, I'm aware that there are now more sophisticated versions, how many times are being promoted as a very, very radical empiricist methodology. I can take examples such as, if you remember, the book Science on Trial by the editor of New England Journal of Medicine, Marcia Angel. And even sometimes, in a strange way, allowing things like evidence-based homeopathy or evidence-based alternative medicine, because in a way, if you take this empiricist turn, in a very radical way, so you can see if something is working from a clinical perspective, maybe we can find a biological explanation later on, but why not using it? And again, I'm not presenting my position, I'm just offering it as an example. Now, we know that, of course, facts, even according to the recent philosopher of science, are not just out there. The whole idea of perceived reality as it is very problematic, and nobody nowadays really perceive the really positivist idea that scientific research can really reflect the world on a one-on-one correspondence with facts. We know that facts are theory-laden, that the very perception of reality and the way in which we perceive as humans those events are theory-laden, and it depends also on theoretical framework with which we approach reality and also on our values. Thus, making some of the evidence-based medicine, evidence-based public health claims to represent a solution to those biases in knowledge production can be sometimes quite problematic and must be, I think, complemented by other approaches as well. But on the other hand, we do not have to accept some radical relativist, post-positivist rejection of rationality in science. I'm sure that some of you are aware of the work of Paul Feyerabend, in order to able to criticize and complement evidence-based medicine. And what I want to do here is to put forward some criticism and then finishing by suggesting some solutions and opening it further to discussion. So one of the, I think, most important criticism of evidence-based medicine is that by accepting quantification and randomized clinical trials especially as the highest form of valid scientific methodology guiding clinical medicine and public health, we assume that medicine and public health are mainly part of natural sciences, and as such being able to represent mainly through mathematical models. However, we know also within public health literature and other publications from social science, especially in humanities, how both medicine and public health are practices that are drawing from both the natural and the social and human sciences. So if we define both clinical medicine and public health as fields of applied sciences that include both science and the art of healing, encompassing a variety of practices evolved to maintain and restore health by the prevention and treatment of illness in human beings, and public health specifically as the science of and art of preventing disease, prolonging life, promoting health through the organized efforts and informed choices of society, organization, public and private, communities, individuals, one of the most famous definitions of public health. It is clear that biomedicine is a fundamental but not solely ground for medical and public health practices. Both the application of various healthcare practices and also informed choices of society, organization, communities, and individuals require the input of the social sciences and the humanities, thus bringing to the fore the question how to include other forms of knowledge and methodologies, especially qualitative ones, as relevant evidence. We do not have to accept a dualistic view by which natural and social sciences are essentially different to accept that the latter are characterized by a degree of complexity, instability, and indeterminacy that make them irreducible to a single quantifiable methodology. So understanding the broad spectrum of public health such as the use of determinants of health, ranging from biomedical to individual lifestyle, community networks, the broader spectrum of social determinants of health. It is quite clear that we demand the use of a variety of knowledge obtained from both quantitative and qualitative methods, and indeed, these are things that are very prevalent now in public health. The second criticism and mostly implicit assumption is that randomized control trials and more broadly statistical inference demonstrate causal relations. Now, we're all teaching our students the difference between correlation and causality, but so many times, you know, when you're going to press conferences or when it's being cited in newspaper, we are turning correlation and statistical correlation into causality, and this is many times the way that is being represented. So randomized controlled trials provide, of course, at best, a relatively unbiased probability statement of the relation between two events. However, the causal relationship is more than a relation of probability. Of course, according to the Bradford-Hill criteria, it requires, for example, biological and conceptual plausibility. And in the field of public health, reducing causation to statistical correlation is even more problematic, since causation in the field of public health is, of course, not only biological, but also behavioral, social, and cultural. Thus, in order to claim causal relationship, we must not only offer plausible biological explanation, but also explanation which address the interrelationship between body, self, and society. However, behavioral and social causation cannot be studied nor explained solely in the term of probability and statistical correlation, but need to take into account a wide variety of methodologies appropriated for the different levels of reality at which claims are made. A third assumption that the correlation found in randomized clinical trial will be completely valid at the bedside or when designing a public health intervention. As Bloom argues, for example, it is assumed that, quoting, any drug that has been shown to be effective in a clinical trial will be effective in clinical practice. However, randomized clinical trials are conducted in an experimental situation where purposely many of the factors influencing the effectiveness of a drug or intervention in the real world were eliminated in order to standardize the context in which a drug and placebo are compared. Now, of course, we have post-marketing studies, etc., etc., but still, I think it's a valid question. A fourth criticism is actually that evidence-based medicine, evidence-based public health embraces, even if not completely, knowingly, methodological individualism. By grounding practice on randomized clinical trials, ignoring social processes that contribute to explain the effect of treatment and intervention, the reduced explanation of social phenomena in terms of facts about individuals, for example, positive or negative reaction to specific drug when compared to placebo. Methodological individualism is very problematic, of course, for practices such as medicine and public health, which, as I argued above, are grounded also in social sciences. Methodological individualism cannot give account of social processes, since, as Roy Bhaskar claims, you cannot give a non-social explanation of individual action, since, I'm quoting, the predicates designating properties special to person all presuppose a social context for their employment. And my final criticism today would be that biological responses are mainly presented as universal, transcultural, transhistorical. And of course, in many ways, this was exactly what was the scientific revolution about. The positivist approach that many times underlies evidence-based medicine does not take into account, unfortunately, many times the social and historical grounds of the research sample. That's assuming that conclusion of a specific set of researcher can be generalized to any population. Now, again, I'm quite aware that there are more sophisticated studies, but I think that still if we take all of what is being published today, or if you're going to do a survey among physicians and public health practitioners, this will still be the main idea. So we know that responses to treatment or to intervention are culturally and historically framed. Social classes, gender, social status are all main variables affecting both the expression of disease and health condition and the response to treatment. The mostly acritical generalization of results is especially problematic since the condition of research are highly influenced by social and cultural conditions. The fact that research is often financed, for example, by pharmaceutical companies with vested interest, The fact that most reviews reflect the priorities of the developed countries and not those of the developing world. This is, of course, very relevant for discussion related to global health, or that many of the treatments or intervention proposed cannot be implemented in a resource-poor situation. So I want now to conclude and offer maybe some solutions. So in recent years, some proponents of evidence-based medicine and evidence-based public health had moderated the former rhetoric that stressed the inability of the regular physician to make rational decisions, and that also presented evidence-based medicine and later evidence-based public health almost as a Kuhnian paradigmatic shift. Yet even though you can find much more nuanced expression of evidence-based medicine in medical literature, and I'm sure in the comments that will follow we'll hear more also about that, usually the former rhetoric and logic remained most of the time, I think, still quite intact when analyzing the common, let's say, medical students or health policymakers' discourses. Decisions regarding allocation of resources, priorities in healthcare and public health programs, evaluation of interventions, all are permeated now with evidence-based medicine language and logic. So as a result, evidence-based medicine many times is still presented and understood as a set of rational choices and piecemeal engineering, and not many times showing the conflict of interest. Maybe in this part there are lots of advantages, I think, in recent years, but maybe more important than conflict of interest, also showing power relations, and even more important, showing what are the values behind some of those practices. Now, this is just one of the caricatures of evidence-based medicine, and I totally disagree with it, but I think that it's not, it won't be maybe so surprising for us how many times the public became also very suspicious of evidence-based medicine. Now, again, the critique that I was showing here should not amount to the rejection of using scientific knowledge in order to improve public health practice or rejecting evidence-based medicine. Evidence-based medicine and evidence-based public health should definitely continue to have a role in medical and public health practice, yet an alternative, more democratic, like in the original version that was promoted in the 70s by Sackett and others, vision of incorporation of evidence-based decision-making into public health should be developed. This vision should not be limited to quantitative thinking, giving a sole role to methodologies deriving from statistics and cost containment methods, but to a more diverse mode of knowledge production. Thus, knowledge produced by a variety of disciplines, ranging from biomedical sciences to social sciences and humanities, and also a much broader diverse stakeholders, ranging from experts, but also NGOs, communities. I know that the WHO is doing quite a lot of work in doing public participation. I think that this finally can inform democratic public health policies. This is not going to happen alone. We need political will to do it. We need money to be invested. Probably some of you did public participation. This is very, very time consuming, and I must say even annoying. But I do think that many times, and maybe in the discussion I can cite some examples in Israel, not doing the public participation finally takes more time, because as we can see here in this slide, I think that one of the most important values in health policy is the question of trust, and this is something that we need to invest. I want to finish maybe with a more kind of humoristic slide. This was published, I think it's well cited. It was published in, there's the humoristic BMJ published during Christmas, and this is systematic review of randomized controlled trials of parachuting. So you can see the systematic review says what is already known about this topic. Parachutes are widely used to prevent death, major injury. the associated with adverse effects due to failure of intervention and iatrogenic injury. Studies of free fall do not show 100% mortality. What this study adds, no randomized control trial of parachute use have been undertaken. The basis of parachute use is purely observational, and its apparent efficacy could potentially be explained by a healthy cohort effect. Individuals who insist that all intervention need to be validated by a randomized control trial need to come down to earth with a bump. So this is the lesson I want to show. And of course, I think there's a really great message here that probably within evidence-based medicine, and I know that there are new ways of doing it, we need to be much more, to think what is our purpose. Sometimes we need to be very exclusive. Sometimes we can be more inclusive. And we can do it in a much more interdisciplinary way and gain also the trust of the public. Thank you very much for your attention.
Thank you very much. Thank you very much. I'm sure we'll have an interesting debate, particularly over the previous cartoon, because you could argue if evidence makes you do all those things, evidence also makes you stop them. And list of medications, most of which are no longer used, procedures that are no longer used because we were able to gather the evidence on harms and inefficacy and cost. And to wrap that all up into one beautiful tool that WHO has developed and promulgated over the last 40 years is our current secretary for the Expert Committee on the Selections and Use of Essential Medicines, Dr. Nicola Magrini. Thank you very much.
So, good morning, everyone. The last two made me slightly nervous, but happy to start with a good engagement. So, the last two slides, I mean, by Nadav. As Lara was pointing out, some of the controversial medicines were that the semi-final slide were actually either resolved by the classical evidence-based approach, that is a good randomized trials. For other, there can be controversy in medicine that can take time to be solved, or on which we can have, when the benefits are marginal, different views. But before going along with just explaining you why the list is somehow on the opposite side, has been a very good flag for the organization, in my view. Well, I have the conflict of interest of protecting my list, but historically quite a defendable topic and with not many mistakes in it. And it was soundly evidence-based in mid-70s. So the point of contact that I was suggested to try to start with is how do we go along? I mean, what's the sense of this? Of the two talks, one after the other. The idea is that evidence-based medicine is not just about clinical trials or randomized trials and the interpretation of evidence. It has been a movement that was able to stimulate a wider reflection and offer a much broader picture around it. Certainly some tension around the dominance of the method can or should be faced, but my articulation and my presentation of the list will be around the fact that certainly a randomized clinical trial is a very important tool, but in the last 20 or 30 years, the movement has suggested as a few other very important dimensions to be considered that are inherently part of the movement. It can also lead us to a better engagement with areas or critique around evidence-based medicine that ask for more participation, better use of different evidence or different kind of evidence that we can probably discuss today. So I will make a short introduction on the list, how it started and why it was a successful idea. Even in an era in the 70s when evidence-based medicine was not yet a coined phrase, and then go along the dimension I just mentioned of very, very important factor or considerations that are with the movement, that I think without the movement would not have been there with such a clarity. These are the need for transparency and the need to governance conflict of interest that can be a pretty wide range of issues. Publication bias and its implication with the major journals and the movement of publishing clinical trials protocol, of which WHO was part from the very beginning, and the meaning of systematic reviews, which is much more important than meta-analysis. That is also another common misunderstanding of my view of the criticism around ABM. So this is the good bit. In 1977, a 30-page book was published, very clear, with a very good team of expert, unconflicted ones, with a very strong secretariat at WHO. Because the secretary of the time, Dr. Nakajima, then became Director General, and a widened secretariat, including some leading experts in the field taken in by WHO as part of the secretariat. The list was a sort of early adopter of the EBM method, that is, was able to put a stop to the many unproven remedies of the time that were mostly drugs for memory loss and dementia, mostly multivitamins, hepatoprotectants, still an unknown question mark, what does it mean, immunostimulant, that was another fairy tale, because the big evolution in medicine has been about immunodepressant. All the new biological are technically all against the excess of inflammation and not in favor of. Osteoporosis and other drugs that of dubious efficacy or dubious safety that were some of those mentioned in the last slide that were never entered into EML. And at the same time, it was able to offer countries a wide range of important options on chronic diseases, on pain. So from the very beginning, both morphine and naloxone were part of the list. A pretty wide range of antibiotics and some basic rules on how to use them very responsibly, that is very little or when necessary. Neglected disease quite prominent at the time. Mental health clearly there with a list that is not so different from what it is now, and cancer. So concise and clear. That for me was definitely a plus. Now the list is 10 times bigger, exactly. It is now, we are publishing it next week. It's 500 pages with 1,000 references. And we have to reflect on whether we go on like that in expanding every year. Not expanding in terms of number, but in terms of presentation. So the guiding principle of the list, I go quickly over it, was the guiding principle, because there was a guiding principle well above evidence, is that a selection of medicines can improve healthcare by making better information, better procurement mechanism, better use of medicine, and also reduce cost. The definition, this is the current definition that was put in place in 2002. It is the medicine that satisfy the priority healthcare needs of the population. In 2002 was deleted the majority of the population, because it has then allowed the entrance in the list of drugs for infrequent disease. Prefer not to say rare, because then orphan drugs becomes a fairly definite legal pathway for drug registration. And the criteria for selecting the drugs were public health relevance or burden of the disease, but mostly evidence on safety and efficacy. But before 2002, also cost was a selection criterion. In 2002 was decided it was not anymore a selection criterion, but became a consequence. Affordability became the consequence of the listing. The first list, just 200 substances or 200 molecules. In the last update, we reached 417, and the medicines on the market are well above 10,000. So the selection is a pretty tough one. And MSF has always been a strong supporter, saying the list was an important breakthrough. We list one medicine per class, which is quite an important message to give the idea to all prescriber, policymaker, that the drugs in a class or within a class are pretty similar. And if they have to be deemed or demonstrated different, it should be based on solid data and important outcomes. So minor differences are mostly irrelevant. This is a strong message somehow against the prevailing market of offering subtle differences to some drugs or to most of the new drugs. So the idea that we are interested in clinically relevant outcomes, this is typical evidence-based jargon, or what actually evidence-based has given further dignity and somehow also a form of teaching and full support of the major journals. By the way, also major journals is somehow an essential medicine concept, because journals have become a very profitable industry. They are well above 5,000 now, and important ones are just a few. So the aim is to improve the health of the population at various levels. So on the regulatory side, on the supply side, on the information to doctor side. If you remember, 20 years ago, the classical term was rational drug use. Now we talk more about responsible and evidence-based, and probably also this definition can be improved. It was already mentioned. Officially, the term was coined by Gordon Guyatt in '91, and it was definitely a successful one. I'm glad to show this good group of friends. I was part of the taking of the picture in February '94. So we were at Mario Negri Institute for the foundation of the Italian Cochrane Center, and where from there was my boss, Alessandro Liberati, who died prematurely 3 years ago. Then David Sackett, the inventor of somehow the strong commander of the Canadian at McMaster, Gianni Tognoni on the ethics of clinical trial and international registration of trial. Silvio Garatini was one of the EML committee in 1977, and Kay Dickerson, who already in '86 coined the publication bias issued. And this is our procedure that went in 2001 through an executive board resolution asking for a more transparent and evidence-based process. You see, the advances in the science of evidence-based decision-making require WHO and EML to take a step forward and to make more explicit rules for decision-making and listing the drugs in the list. And this was done by this executive board resolution. I will not go into all the details, but I already mentioned the deletion of the majority of the population as part of the definition of essential medicines. Quite important this year. Because of this, we were able to include many important drugs, or some important drugs for leukemia that are typically rare diseases with highly effective treatments or regimens available. But the criteria are now more clearly reported: disease burden, but in particular evidence on safety and efficacy. And absolute cost is stated in the resolution will not constitute a reason to exclude a medicine from the list if it meets the established criteria. So Hans Ogeside, the director of the time, wrote in the BMJ that affordability changed from a precondition into a consequence of the selection. True, pretty optimist, but still, let's say the advocacy role WHO has in asking for important changes in how the market goes. But also it was quite strictly put in place a process to manage the conflict of interest, and a very good oversight in expert selection. And in 2008, WHO finally adopted a grade methodology for its standard guidelines. That has been quite a step forward. But other considerations are regularly made when examining a drug in terms of regulatory status, including off-label inclusion when good evidence is available. True availability, we have included drugs not yet produced in the world because of supporting the starting of the production, typically zinc sulfate 6 years ago, and guidelines, especially WHO guidelines, as an important, let's say, alignment in terms of WHO policy. So in 2002, that change allowed for the inclusion of HIV patented medicine that were high cost, and that's why we had to change cost as a selection criterion in order to include the very important HIV drugs in our list. And certainly the participation of NGOs and patients, but also the government around the HIV access campaign were extremely important and part of this success. Well, just to be as provocative as some of Nadav's statement, EBM has been also rated by, in this case, Kay Dickerson and Lisa Barrow, as one of the 15 milestones that 10 years ago the BMJ asked for. What were the 10 or 15? What the most important milestone in the last century? These were listed, goes from antibiotic to vaccines, and also EBM is there. So certainly the movement has had an impact and quite a high profile. And I would just quote a few friends of the EBM movement because they have widened the agenda of the movement. This is Drummond Rennie, former editor or co-editor, both New England and now at JAMA. And this is one of his famous statements that I particularly like, and was part, in my view, of the movement and the beginning of the peer review Congress that is held every 3 years. Can go quickly through. There seems to be no study, too fragmented, hypothesis too trivial, literature citation too biased or too egotistical, design too warped, methodology too bungled, presentation of results too inaccurate, obscure, too contradictory, no analysis too self-serving, argument too circular, no conclusion too trifling or too unjustified, no grammar and syntax too offensive for a paper to end up in print. So this is the quality of most available studies published in the literature. So the problem of how to screen them, how to make them usable, how to make them reliable was part of the EBM movement and part of the great working group. So what has now become a standard in terms of transparency and conflict of interest is we have in place a full transparent process. We publish the application, we publish the reviews, the referee's comment, we publish the final TRS, we publish any letter we receive. So we'll not go into that detail. But also conflict of interest was very important. WHO was one of the organizations paid more attention to, for example, the negative influence of tobacco producer in funding the right or the wrong research. So in this paper, Lisa Barrow warned that the conclusion of the articles depend on the funding sources. So she started with passive smoking, and a few years later she published the same for clinical trials that were funded by the pharmaceutical companies. And just a few things on the publication bias that is so important and part of the movement and probably less known. And so Kay Dickerson already in the late 80s wrote this fantastic definition: tendency toward preparation, submission, publication of research findings based on the nature and direction of the results. That is, the researcher is less interested to send his negative trial to a journal, who is less interested in publishing it, and the reviewer is less interested in giving a positive comment. Why is so important? Because if you publish only the positive result, this is an analysis with the studies for registration of new antidepressant at the FDA, you can see that all the positive studies, 37 out of 38, were published. The negative trial were 70% of them were not published. And if you make a meta-analysis out of the published studies, you overestimate the effect of 30% or more. That is to say that it has been essential to publish the study protocols. WHO established a platform on clinical trial protocols, pooling together the various sources from clinicaltrials.gov to others in order to let researchers and agency have access to this very important source. Why are protocols so important? Because in another study where Kate Dickerson and Lisa Barrow, by the way, is also chair of our expert committee on essential medicine, so it is a conflicted for me, friends, in terms of quoting her preferentially. But she made, in my view, this wonderful study also in terms of graphic, where she showed that out of these 20 studies, that the majority changed the outcomes in the protocol in order to make the outcomes significant. And if they had examined the outcomes of these studies for the off-label uses of gabapentin, most of these studies would have had a negative result and not a positive one. And the very strong conclusion that these two authors make is that even the Cochrane review that was based on the published studies is not reliable, because you need all the studies that were actually done. So the primary source for our systematic reviews should be the registries and not the finally published studies. Not easy at all. I mean, more work for. And this year in April, our group of vaccines, Vasi Morty, but also our ADG, Mary Paul, wrote this very strong paper on supporting full access to available studies. That is still an ambitious goal to have, and not an immediate one. I've almost concluded. Just a few reminder on why are systematic reviews so important, and more important than meta-analysis, to reduce some misleading messages. Systematic are important because you by analyzing single studies, you miss the overall picture, so-called missing the forest by looking at each tree. So first you have to realize whether your evidence base is a small bush or just a few plants, or is a large basis. That's the first important message. I was talking about just a few hundred patients, well or badly randomized, or a solid base. And then you start evaluating the quality of the studies. That is what the Cochrane has been establishing, and what in the jargon of Cochrane, and I look at Lorenzo now, is the so-called risk of bias of the studies, what we usually call the quality or reliability of the studies. And then by a systematic review, multiple authors, usually systematic reviews are not a one-man enterprise. The multiple authors go for a long effort to scrutinize better than what you usually do by reading the studies on your own, which this is also part of a good guideline process that we try to support with the GRC internally. And they focused on the issue of heterogeneity among studies, why sometimes apparently similar studies give contradicting results, and magnitude of effect, how to estimate, how to have a common scale in order to reach the clinical relevance or the public health relevance. So the magnitude is a continuum, but we very often are interested in large or high impact results, or highly effective drugs. For vaccines, usually, most vaccines are highly effective. An example of what we have with us in our applications, for example, we this year included all new direct acting antiviral for hepatitis C, quite a big move for WHO. And this is a very good example of one application, the best we had, with all the studies presented, but also would like to stress this for this audience, all the studies that are still ongoing, that will offer very soon their results. So the idea that our knowledge acquisition is a continuum process, is an evolving one, is quite an important one. This year, we included these new drugs for hepatitis. We have been inclusive usually we tend not to be, because we thought that by including we could promote competition and allow for optimal combination of these drugs. So somehow we interpreted existing rules, trying to adapt them to the need of this particular chapter. But also we tend to underscore the importance of further research or more comparative research or head-to-head comparison that we are in need of for these hepatitis C drugs that are already highly effective, but the optimal regimen is not yet there. So just to quote another father of EBM, Doug Altman, we probably need less research, better research, and research done for the right reason. That was a BMJ editorial a few years ago. So we have, as WHO, adopted GRADE for our very wide range of guidelines and documents. This has been quite a bold decision to try to have a common methodological approach. Just want to stress that quality of evidence means confidence in estimate. And if we are driven by that concept, we are pretty confident in the estimate that parachute works and works so well that it does not need a clinical trial. So randomization is not necessary, like for insulin or for some leukemia drugs. When they are so effective, you don't need a randomized trial, and just with a case series, if before no parachute they all die, and with parachute they all live, you don't need a randomized. It would be unethical to perform. So the gynecologists that were very upset for being reviewed too carefully in many things they do, went, of course, that was a provocation over Christmas. And we tend to use grade tables for all our guidelines as the important basis for our or guideline panel decisions. And the system is flexible, so we can have strong recommendation also with weak evidence, and this has to be justified. And so the method again support transparency and allow the reader to understand what was done. It's still an evolving system in chapters like equity, economic evaluation, and also observational studies for safety, including environmental studies. There is room for further reflection and further progress. I have no conclusion because I think the movement is let's say well and alive, and has probably brought us to a point of no return. So this quotation from Kafka can be good. There is similarity. From a certain point onward, there's no longer any turning back. I think the EBM movement has brought us there. Now there's no doubt conflict of interest is an issue. We have to manage it. Publication bias is an issue. The quality of the studies is an issue. And I think this is one of the merits. I conclude with an optimist remark from Richard Smith, before retirement from the BMJ, wrote a short lecture for medical students, and he said that the future that is so difficult to forecast could probably, though the world changes, what is probably persisting should be, or could be, I hope should be, clear ethical values, clear about the purpose of our organizations, putting patients first, trying to improve, basing what we do on evidence, that's why I'm quoting it, leadership, education and learning. Thanks a lot. Hoping questions.
Okay, thanks very much for staying with us. Now, to moderate the lively debate that I'm sure you're going to have here is Professor Sanjoy Bhattacharya from the University of York, who has our collaborating center for the Global Health Histories. And he will take your questions. Thanks very much. I'm sure he has some of his own.
Thank you all. If I could just remind you that if you have comments or questions, please identify yourself. I think we have online a good number of people online who'd like to know who you are and hear your comments as well. So, I mean, if I could quickly just, Nicola, as a historian now working on the history of primary healthcare and the journey to universal health coverage, the preparation of the essentials medicine list was very, very important for the primary healthcare movement as a whole, and for me represents very strongly the support of the nations who supported the idea of primary healthcare. This is one of the ways in which they had their voices heard. I can think of countries like Sri Lanka, countries like India making a point. So where do you see what you've just described within this new universal health coverage narrative that is now emerging from WHO very successfully and being exported even to the new UN Declaration on Sustainable Development? And Nadav, I mean, you raised wonderful comments about communication and public trust. Your discussion, I think, was about public trust more than anything else. Where does multilingualism play a part? Because, again, as a social scientist, as a historian who works with social scientists, I can't help but I wonder if I would be working with the WHO if I couldn't speak fluent English, for instance. I mean, English dominates. So where does multilingualism play a part? I work very closely with Brazilian colleagues, and one of their great annoyances is the lack of materials in Portuguese, for instance, or Brazilian Portuguese. The assumption that European Portuguese is the correct version of Portuguese is also annoying, and you lose alliances. So would you have any comments on that before we move on?
Okay, first I want to thank Nicola for the wonderful presentation, and I think in many ways I see it as complementary. By the way, the last two slides were one first to maybe wake up the crowd. And mainly also to show not my point of view, but kind of returning to the question that Sanjay said before is the question of trust and how it's sometimes being represented by the public. I'm dealing also with resistance to other kind of movements, for example, resistance to vaccination. And I think that it's extremely important to have, and I know that you, from our discussion before, that you're also thinking about it, that there should be a dialogue. And I think that usually in the history of public health, medicine, public health, sometimes what has been perceived as resistance and annoying, etc., many times it made you rethink. And finally, it's a question of responsibility, because I totally agree. You mentioned these 15 things that are, among the highest, and I think it's also a responsibility of the people from EBM. And as you presented, the things that you are doing, because finally it has amazing deep consequences, social, cultural, economical. Sanjay, you mentioned primary care. So there are many more consequences that we even didn't start to discuss today. I still think, and I'll be happy maybe to hear later, that even after your presentation, that still there's a lot of work that I think you admitted, especially with the qualitative part. I still didn't see how the qualitative part is finally entering. And what I want here to discard is that many times we are thinking that, there'll be the people that are going to, let's say, the people arriving from clinical sciences or epidemiology, that they will organize the study, and then finally they will give it to the historians or bioethicists. But this is too late. And I want to hear, maybe I'm not aware, how in the WHO and other places, how you're building a mechanism that from the beginning, actually, when planning the study, and of course, by the end, analyzing and also presenting it to the public, how we can have people from the social sciences and humanities being involved, because this is not going to happen by itself. If we're not creating the mechanism, and the different ways I'm thinking, but I'd be interested to hear what is your perspective. Now, Sanjay, for your question, of course, I didn't. This is a great point. And I'm from Israel, so we have both studies published in Hebrew. We have from the Palestinian Authority, lots of information also in Arabic. By the way, I'm ashamed to say that, for example, I don't know Arabic, and this is it's an impediment for me living in my country, so I think it has even deeper consequences than just but regarding evidence-based medicine, this is, I think, another consideration that why we should bring historians and social scientists. I think especially historians are much more sensitive to these issues, and if you have them in the room. Now I want just to mention an alternative. There was a committee about Agent Orange. Agent Orange was a herbicide, and after the Vietnam War, more and more veterans were claiming compensation, etc. This was totally discarded. And finally, there was a committee, and what was really amazing that when they're doing, let's say, this kind of systematic review that I totally agree that in many ways more important than the meta-analysis, they were having information in different languages. They were aware of it from the beginning. They were also including other studies that probably in a meta-analysis were not there, and they were very aware of it, and probably also because finally there's a question: what is your final goal? Because to include a new drug is one thing. To discuss a social question: should you now give compensation to veterans that were sent by the country? So maybe it's a different level of evidence. So I really like also what Nicola, you said about the confidence of, and it's also related to the question: what is your final goal? So multilingualism is I think it's a challenge in general, and I think it's one of the things that bring again this notion of how we need to join forces and have more people being involved, anthropologists, of course, etc.
Try to recapture the many things. Well, first of all, Sanjoy was mentioning the beginning. The beginning in the ML4 was for primary care. It was a very important moment or decade. Was Health for All, was establishing basic healthcare system, and so the EML was a good tool for that. Now we have expanded the list under the bigger umbrella of universal health coverage. That's why we included also more complex issues such as tumor that are very often an integrated approach, hospital-based and much more complex. But we included drugs for hepatitis C that, like HIV, are or can be very important in the case of hepatitis C, even to reach the elimination of a disease. But the change in framing was important because then you are actually repositioning the list or giving more complexity to it or to its implementation. Some of the other issues try to. I was certainly offered an easy position by defending a short list of medicines where the requirement for strong evidence coming from clinical trials is well accepted, or though the tendency is for going for faster approval, there is a lot of tension around whether this is sensible or not, whether this is mostly market-driven or in the interest of public health. Remaining on the broader issue that was asking me about, is the evidence always the same? On the evidence we need and we rate, is it always the same? Certainly not. So if you want to evaluate a new drugs for an unknown disease or for a very severe disease, what you require are some strong data that it works in reducing mortality. It was for Ebola last year. We try to find an effective or a highly effective intervention, not just a mild one. If you want to have some data about an environmental risk, you rely on different evidence and we tend to to define it as best available evidence. It means best available evidence for your purpose, acquiring all what is known and what can be used in order to support your decision. And very often the health policy decisions are just informed by best available evidence, taking into account all the rest. So sometimes you can be more conservative or more loose in your threshold level for accepting that. On qualitative studies, I would like to just introduce the fact that among the various chapters touched by the EBM movement, also in the publication, there has always been some stressing over the fact of patient values, patient attitude, and they've always very often acknowledged that that was the weakest, probably because the methodologists were not expanding that chapter as they did expand the more quantitative one. So what is a patient relevant outcome? What do patients think is of course a priority and a common interest. And how to integrate the different approach can be a challenge, and we should reduce some of the initial tensions that can be there. But we should do something.
Before we go on to a question posed online, would anyone like to ask a question, make a comment? Sir, and please identify yourself.
Hello, thanks for the presentation. I'm Olivier Talpin, an anthropologist at the University Institute of History of Medicine and Public Health in Lausanne, in Switzerland. And my question is to Nicola Magrini. You mentioned your wish that social scientists would be involved in medical research at an early stage. Since I'm doing anthropological research on medical research, that is more specifically on modern research on traditional Indian medicine, could you please develop a bit your wish, and maybe you could mention the main contributions you would welcome from social scientists involved in at an early stage in medical research?
You mentioned me, but I think you want Nadav.
Sorry.
No problem.
You're right.
Yeah.
I meant
Nadav mentioning the anthropologist, then Nadav will reply.
I'll give you an example from a project we have now. I'm working together with a medical anthropologist. We have in Israel, in the Negev, a problem with brucellosis. It's an infectious disease transmitted by unpasteurized milk. Rates among the Bedouin population are 200 times more than the average among Jewish population. And it's quite clear that we know lots of evidence-based information from other countries, but still things are not working. Sometimes you call them wicked problems, and it's quite clear that in order, for example, to have a collaboration between the veterinarians, clinicians, public health professionals, and of course the Bedouin community, including the farmers, we found it very important and very useful to have also the qualitative, especially anthropological studies, and we're doing it in different ways, in-depth interviews, focus groups. And unfortunately, what happened that before using this kind of information, the Israeli Ministry of Health failed to change, and the situation even got worse. So we created a collaborative team where we have also anthropologists. Another problem was related to congenital malformations and high infant mortality rates among the Bedouin population. So, an evidence-based intervention, and maybe it's related, and I'm sorry, Sanjay, that I'm answering maybe also question number one. It's great talk about evidence, but no comments about implementation. So what are views about which type of evidence best to facilitate improvement of practice? So I think it's very related, because you know, saying to the Bedouin community, congenital malformation, you know, happen in much higher rates when you have consanguinity. But you cannot just go and say, okay, so stop marrying, you know, within the family. This would be, this what happened for many years, and it led to nothing. So already in planning, you know, the different studies, but also in the implementation, in both of these cases, you know, it can be brucellosis, it can be infant mortality rates. This will be very useful. Now, I want maybe to say that I don't want to sound, you know, as a kind of, it's only when it's a Bedouin community, you know, or some, we can speak about, you know, in Israel, we have different hegemonic groups. We can speak about, you know, elderly Ashkenazi people living in Tel Aviv that you want to do an intervention about regarding diabetes or smoking or whatever. I think that in all these different stages, especially anthropology can be very relevant, but this is true also, as I said, you know, talking about brucellosis, just understanding the history of brucellosis and the history of the interaction between the Bedouin community and the Israeli state would be extremely important when you are doing your intervention. So I think it's also answering the question about implementation that, again, I think we need to diversify our knowledge, sources of knowledge. And again, this is not going to happen just because we want it. If there won't be political will by, again, if you're talking about the global level, so places like World Health Organization, or if you're talking about Israeli Ministry of Health or universities, usually people are not collaborating. I have a PhD student now who's working on health in all policies, and the main question is how to bring, in terms of governance or in terms of the political will, that this actually will happen, because everybody is talking about it, but there are so many barriers, structural, historical, and if you're not going to understand them, it will be very difficult to move on.
Sorry. We've run out of time. I'd like to thank the two speakers and WHO colleagues who've helped us organize this event. I think there's a lot of food for thought, and I hope people who've been online get in contact with you. Next month, we have a GHH seminar on air pollution and a speaker from the United States, who I think will be working with our colleagues and presenting with our colleagues from Public Health and Environment. So thank you all for being here.